So going back to our discussion on granulation tissue. So what if you have this type of wound? So if you see a granulation tissue and they are not enough to fill the defect, okay, like in the case of this wound, what is the term for this? So the term is hypogranular tissue or a hypogranular wound bed. So is this good or bad? It's bad because epithelial cells epithelial cells coming from the edges of the wound cannot dive down to attach themselves to a granulation tissue. Okay, so this wound may not reepithelialize unless the granulation tissue goes up a little bit higher so that the epithelial tissue will attach themselves to them. Okay, now how about if you have a different type of wound and you see the granulation tissue growing over the edges of the wound, going over the limit of the surface of the wound. So what is the term for this? The term for this, ladies and gentlemen, is a hypergranulation tissue or a hypergranular wound base. So is this good or bad? It is bad. You know why? Because much as the epithelial cells cannot dive down over a hypogranular wound bed, they cannot also jump over, okay, a hypergranulated wound bed. So resurfacing or reepithelialization will not happen in both situations. So these are the two things that you need to make sure that you're looking at these patterns of granulation tissue. If it's hypogranular, you have to find all means to manage what is causing the sluggish growth of the granulation tissue. Now, if they are hypergranular or there's a hypergranulation tissue, you need to manage also this granulation tissue. There's a lot of ways to do that. So now, there are causes of the wound base to be hypogranular or the sluggish growth of a granulation tissue. And and also different reasons why the granulation tissue would overgrow. Okay, and it's beyond the uh, scope of this discussion, or else we're going to be there. This video will be very, very long, but let me just give you a little bit of bird's eye view on what is going on in here. So if you have a hypergranular tissue, which is very notorious, especially after surgery, there are three things that you need to think about. Is there so much moisture? That's number one. Okay, maybe you are not absorbing the exudates adequately. Number two is there any silent infection? So if there is a high or critical colonization, okay, most of the time or sometimes the wound bed would tend to hypergranulate, and there are also other factors. Okay, so then there are several ways for you to manage a hypergranular tissue. Okay, you can put pressure, you can manage this with silver nitrate, and lately I have tried a very anecdotal way because I have this patient that has been seen by the dermatologist, and the wound wasn't closing because of the hypergranulation tissue keeps growing. It's regardless what we do. They have been managing it with silver nitrate and whatnot, all those um, typical ways to manage hypergranulation tissue has been done, but nothing has had worked. So he came to me. I did the same thing, and it did not work at all. So I was reading the literature, and there were some clinicians that were putting like a topical what do you call this, hydrocortisone, 1% hydrocortisone on the wound bed every day. And that's what I did. And the granulation tissue has been suppressed significantly, and the wound has reepithelialized. Okay, so from this slide, you learn that there's hypogranulation tissue and hypergranulation tissue. If you see this, you have to note them and describe them as such. And you know that you need it to be managed, or else the wound is not going to close. So let's move further and let's take a look on the wound edges. So if you want to know anything about the wound, just look at the wound edges and it will tell you everything that you want to know. As a wound investigator, okay, by just looking at the wound edges, it will tell you a lot of information about the wound, about how old is the wound, the etiology of the wound, in whether the wound is gonna close soon, or the wound is stalling and whatnot. Okay, so in this picture in here, the first picture that you see, okay, so you can describe this as either attached, okay, or not attached. Okay, so you know, ladies and gentlemen, that an attached wound edge would close, right? If the wound edge is not attached, it will not close. Other way to describe this too is that attached and not advancing, or attached and advancing. If you see some movement of the epithelial cells or epithelial tissue moving forward here, and then you can describe this as attached and advancing. Okay, and this wound that you see on the second picture is, if you look at the, the, this edge here, ladies and gentlemen, it's curled in, it's curled inward. Okay, so this is what we call epeboly. Okay, so when you see this type of wound edge, okay, you have to describe this as epeboly. So this is curling in of the tissue. You know why? Because look at the wound bed. It's hypogranular, like what we said earlier. So the edges were waiting and waiting for so long, okay, and then they're ready to migrate and move forward, and they were looking for a place to attach, and they couldn't attach because this is so deep. Okay, so what they did is that instead of moving forward, okay, they went down like this, and since there's no place to attach in this area, they curled in and looked for another place. Okay, so instead of going forward, they went like this. Okay, and then once this epithelial edge will reach the another epithelial surface in here, okay, they will go into what we call the contact inhibition that we described earlier. Okay, so now when there is a contact inhibition, that would send a signal to the brain that, or to the body, that the wound is already closed, and it will bring about the chronicity of the wound. Okay, a lot of the wounds that referred to our service, when we take a look on the wound edges, when I see this epeboly that has not been managed, I was telling myself, what were they waiting for? Okay, because once the edges curled like that and go into epeboly, okay, that sends a signal to the body that the wound is closed. It's no longer the priority of the body. And sometimes, if you see a wound base like this, you would it's not surprising that you don't see a lot of inflammatory response at the periwound when you see an epeboly. Okay, you know why? Because like what I said, it's no longer the priority of the body. The body has forgotten about this wound because of the contact inhibition. The body thought that this one is already closed. Okay, and the other way for you to for these edges to curl in is that even if, okay, even if assuming that the wound base is granular and they were able to attach themselves to the granulation tissue, if the wound base here is so dry, okay, there are the epithelial tissues, the epithelial cells cannot migrate over a dry wound base. So they're gonna look for a moist environment. So and it's usually it's the inside environment that's moist than the outside environment. Okay, so this is the reason why they follow that moist environment until they meet another epithelial cells inside, and then they go hello. Okay, they greet each other, and then they stop migration, and like what I said earlier, the body would think that the one is already closed. So this needs to be managed. Okay.